Welcome to a very special podcast that is part of a series I am leading on diversity and inclusivity with CME Outfitters. Today's CME cast is Closing the Gap, Disparities in Oral Health and Access to Dental Care. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I would now like to welcome Dr. Hazel Harper, the founding director of NDA Health Now and a past president of the National Dental Association. Dr. Harper, I'm honored to have you joining us today, and I'm excited about the discussion. You're truly inspiring, so please tell us what inspired you to work for oral health equity.
Well, thank you so much for having me. It's always a pleasure, and thank you for paying attention to oral health when so many people do. And I just have to say, I am a semi-retired practicing dentist in Washington, D.C. I do have a master's in public health, but I was a very, very busy private practitioner in dentistry up until 2007. I used my master's in public health to help organize dentistry and to continue to advocate for oral health and to increase access. But it wasn't until 2007 when a little boy died named Diamante Driver in Prince George's County, Maryland, from untreated dental decay. And when I found out that that little boy's school was 5 minutes from my house, honestly, I found out about it like everyone else, reading the newspaper. And I knew at that precise moment that something had to be done because I couldn't come to grips with the reality that children were still dying in my country, 5 minutes away from my house, because of something as preventable as tooth decay. So since then, I have just kind of immersed myself into increasing education, increasing access, and increasing awareness about the link between oral health and overall health, and especially when it comes to our most vulnerable population. So I'm pleased to be able to continue practicing dentistry because my patients are my sounding board. They let me know that I'm doing the right thing by continuing to address this in terms of oral health. And they let me know how little information there is out there about the connection between oral health and overall health. So I'm so pleased every time I get a chance to really talk about this. So thank you.
And thank you. I think that your story is an inspiration to people and to providers to say that, we all have a role to play in social justice, and that certainly taking care of our patients is that's what we have been trained to do. But we also have an additional role in fighting for justice and in making sure that those who have are at increased risk for dying and for disease, that we help work to change laws and policies and practices so that they can live in an easier way, and that we can step outside of our role of the white coat and still be just as effective, if not more effective, in impacting people's health and well-being. So thank you again for being with us today. So let me start with our first learning objective, which is to identify structural and social determinants that contribute to oral health disparities in the United States. And that's something that we were just talking about. So Dr. Harper, we've discussed before health disparities, and we know that those are a result of many factors. And so what can you tell us about the root causes of health disparities in oral care?
Well, I think the most obvious one is that medicine and dentistry have been separated and segmented for so many years. And it dates back to really the Flexner Report in the early 1900s, and how there was a very significant and intentional influence to make sure that medicine was viewed as the top of the chain, of the top of the pyramid, and that all other things were going to be subservient or very, very below medicine. So when that happened, and the subserviency almost is analogous to some of that implicit bias and structural racism, where you have different segments of the population that are at the top of the pyramid and others that are way down below in terms of a subordinate position. So that was really where it started, and it has continued. And the problem is, as I see it, there's not nearly enough time spent in the training institutions of non-dental professionals. The physicians and the nurses and the pharmacists, honestly, some of the most recent surveys show where in terms of actual oral health in the curriculum, they're less than 5 hours of oral health that is in anybody's curriculum. About 70% of the institutions up to a few years ago had oral health in the curriculum. So when physicians and nurses have that limited amount of oral health training, either in their undergraduate curriculum or their postgraduate residency programs, the expectation and the knowledge base can't be the same with regards to just basic knowledge of oral health. So there comes a time when we really have to realize that in order to make sure that there is the same amount of attention paying to oral health as a critical component of overall health for physicians and nurses and pharmacists as the training that dental students receive with regards to medicine. And most dental students are receiving 2 years of medicine, which is completely different than 5 hours of dentistry or oral health. So there's a huge knowledge gap. So that also really counts. What is helping is that there has been a recent mandate for interprofessional education, which has been given to the institutions of training. And that is great because now there is more emphasis and more focus on that. I'm still waiting to see where the best practices are with regards to that didactic training translating into clinical care. It becomes a little bit harder because of the way that the systems are set up, the way that the insurances are coded, the way that electronic health records are put together. There are a few institutions that are working really hard to change that, but far fewer examples that are really out in the community in terms of clinical care.
So I'm glad to hear that there are forward-thinking changes coming, because I can testify that when I was a medical student, we got very little in this. And I always hear about the Flexner report in terms of the damage it did related to disparities within medicine, but I had no idea about the relationship between dental school and medical school and all of those kinds of things. So it's really important for me to hear, and others who are listening to this, to understand that history as well. Can you talk a little bit about some of the social determinants or structural determinants of health that affect health disparities in oral health?
Well, I'm so happy that we're talking about it, and more attention is being paid to these social determinants of health. We're much more mindful about that than we ever have been before. And I'm really glad that it's out there, because whatever are the contributors to disparities in oral health are the same as the contributors to disparities in overall health. So we still have the barriers of economic barriers. We still have the educational barriers. We still have the lack of literacy when it comes to oral health and when it comes to overall health. We still have barriers created by transportation, where a lot of times people of a lower socioeconomic status rely more on public transportation in order to get anywhere where they're going. We still have barriers that are created by folks that don't have childcare, that maybe can't take off from their work, where we don't have enough dental providers that have extended hours, so that people that are even trying to get to the dentist and can't go during the day don't have enough places where they can go after work or on the weekend. So there's still those kinds of barriers, social determinants of health that are barriers. And we still have that whole range of vulnerable populations that the Surgeon General's report on oral health talked about now over 20 years ago, but they're still there. The elderly, pregnant women, disabled population, the children, especially the young children, and so many others that have been identified as vulnerable populations. So you put the vulnerable populations along with the social determinants of health, and you add the structural racism or some of the implicit bias that has been built into a health system. And it almost seems like we're going in a vicious circle from one generation to a next generation. So really, it is so gratifying to be able to talk to folks who have a basis for concern and who are genuinely interested in trying to eliminate those disparities and break down those barriers. Because myself included, I have had what I call a reawakening. A reawakening. The COVID pandemic sort of backed all of us into a corner where we couldn't do anything else while we were in quarantine, but read and attend webinars and try to achieve a higher level of consciousness, which is what I've been able to do.
Excellent, excellent. So you had mentioned some of these vulnerable populations. In addition to children, pregnant women and older individuals are more vulnerable to disparities in oral care. What does this impact have to do with from a long-term health perspective and quality of life?
Well, it's amazing. And the more that we're able to increase awareness about the impact of oral health for the long term, the better it is. Because even though we're talking about pregnancy and the importance of dental care as a part of prenatal care, it really should not be optional. It really should be mandatory. And we should have more than just 40% of our dentists and OBGYNs that are even talking to each other about the importance of prenatal dental care. But moving further, so we already know that poor dental health contributes to negative birth outcomes. It contributes to low birth weight infants. And coupled with the fact that in the African American community, we have grave concerns over the fact that the incidence of maternal and infant mortality is increasing in African American women and not decreasing. And once we know that oral health can play a negative role in outcomes, well, we have to increase awareness about that among especially that population. But what is also true is that there's still so many myths that have to be dispelled when it comes to providing dental care to pregnant women. And I mean that we have to have retraining of our professionals, our physicians and our dentists when it comes to that, so that they know that there are new policies and guidelines that are out now that encourage dental care during pregnancy. But the other thing is pregnant women don't realize, and they won't realize unless we really do a better job of educating, that what happens with them in their oral cavity while they are carrying their baby will impact that baby. Yes. So that mothers that have a dental disease will have children that have a higher risk for dental disease and dental decay. Mm-hmm. So we already know that 1 out of 5 children between 2 and 5 years old have tooth decay. But I don't know how many people are still realizing that it's over 50% of the teenagers 12 to 17 that have tooth decay. So it hasn't gone away, and tooth decay and gum disease are both preventable. But unless we really do a better job of educating our mothers to be and our young mothers, we're talking about not only prenatal dental care, but perinatal dental care, maternal and child care, it all goes together. So we do have to do a significantly better job of educating. And there are so many different ways now that we can get the message across.
One of the things that you had mentioned was training our young professionals. And so We know that healthcare inequities and biases can occur in education and training programs. And you had mentioned earlier that data shows that dentists from minority backgrounds are more likely to serve in underserved patient populations. What can you tell us about diversity among dentists and how this is a source of disparities in oral care?
Oh my goodness, I'm so glad you asked that question because it is so terrible to me that after all of these decades, we are still stuck at the small percentage of African American dentists that are actually recruited, matriculated, and graduating from our dental schools. A lot of it does have to do with recruitment efforts, but along with that, it's not only about recruitment. It's about providing financial assistance, and it's about providing mentoring, and it's about giving them a very smooth transition from dental school to mainstream dentistry.
Mhm.
So there are a lot of factors that go along with that. And if we really just take a close look at some of those structural barriers and some of the barriers that have already pointed to implicit bias and explicit bias in the education of our students. And we have to see that there's probably many, many, many factors that are involved with that still low percentage. But as you said in your opening statements, unless we are in a position to make a difference with regards to policy, with regards to allocating resources, in order to be able to change these long-standing situations, and nothing will ever happen.
Mhm. Mhm. Good point. I want to tack a little bit now and talk a little bit more. You have been discussing the importance of oral health within the context of overall medical health and those linkages. And you've talked before, I've heard you about oral health in the context of the COVID pandemic that we're currently experiencing, and how those two things have been linked. And so, can you talk a little bit more about oral health and COVID?
Oh my goodness, that is so important because, we talk about the vulnerable populations and we also talk about disparities in health. And that brings us to all of the populations, the brown and black populations, that are the people that are at the highest risk for all of these morbidities and all of these systemic diseases that will contribute to the duration and the severity and the outcome of COVID-19. So when it comes to oral health, um, there's been a lot of research and there's ongoing research about how oral health can really contribute in a very, very negative way to not only to respiratory diseases in general, but to diseases that are surrounding COVID-19 when it comes to these severe um, pulmonary diseases that are associated with COVID. So if you have in your oral cavity, if you already have advanced periodontal disease, and if that is not addressed, and let's face it, our first responders or emergency room responders in the hospital, oh my goodness, they are so overworked already and not in the habit of doing any kind of real intraoral screening or intraoral evaluation to even know whether or not the patient has any kind of advanced periodontal disease. They don't know that they may actually be contributing to ventilator-related pneumonia by pushing more disease into the lungs as they have to put those patients in ICU and they have to deal with those kind of things. In dental practices now, as part of the protocols that we put on top of all the other universal protocols that dentists were already doing, we have layered the protocols with a pre-procedure mouth rinse so that we actually are able to make sure that we're oxidizing any virus that may be standing around in the patient's oral cavity. We're mitigating all of the aerosol procedures, and we are using so many different things to make sure that we protect ourselves and our staff, in addition to all the pre-screening questions that we're asking right now. So if our non-dentist providers and if our emergency personnel that are in hospital settings knew a little bit more about this and were able to administer any kind of, even if the patient is not in a position to be able to do rinsing or whatever by themselves, even if they were able to swab out the oral cavity ahead of time or on a routine basis, 2 or 3 times a day as part of their protocol, I believe that it would really have a significant impact, because if a patient has a periodontal disease or any of these bacteria already in the mouth, it does definitely, the research findings show that it definitely correlates to the duration and the severity of the COVID-19 virus.
That is fascinating. And it's actually a wonderful segue into our second learning objective, which is about interventions. So we've talked about this critically important problem of inequities in oral health and their impact. So we're going to turn now to talking about our second learning objective, which is to outline steps to eliminate these inequities and to provide more equitable oral health care. So one of the things that we had already been talking about, it is so baffling that our teeth, that our whole sort of oral health care system is not included as part of the medical care system. And I'm just learning myself as to sort of the historical reasons for why that's so. What do all healthcare professionals and patients need to know about this link between oral care and the rest of the human body and systemic healthcare and systemic medicine?
Well, the mouth can't be separated from the rest of the body. People try, but it really can't be. So everything that takes place in the mouth is transported through that highway system of veins and arteries and all of that stuff through all the rest of the body. And that's why you have so many situations where we have diseases that are definitely linked to oral health. And there are many, many, many. And every year, the researchers are coming up with more and more. So it's like, if our non-dental health professionals aren't really learning about these correlations between what's going on with the inflammation and bacteria in the mouth and how it's linked to so many different cancers and even Alzheimer's disease, not to mention, we talked about, the negative birth outcomes and the increased risk for severity and duration of COVID-19, but so many other things. If people don't really learn that as a basic part of their training as health professionals, it's not going to stick with them, number one, and they can't expect it to be proficient in counseling their patients with regards to whole body health. Because the dentists always say that nurses and physicians, and I can't really use that broadly because we have a lot of programs now where nurses are really more so than physicians taking courses that will enable them to feel more competent with hands-on evaluation and oral health screening. Before, we used to say, it's not unusual for nurses doing their basic screening and evaluation to go from the lips to the throat, not look at anything in between. It's from the lips to the throat.
It is so true.
So we're trying to change that. And there's some programs and institutions, and there are also some extramural programs, and I'm part of several of them that also are really, really training nurses to be able to do a much, much better job of that.
Excellent. So what are some of your recommendations for closing the gaps in oral health?
Well, the first would be to improve the interprofessional education, as we know that, both in the training curricula and in clinical practice. I always feel that the best way to do training is community-based. I always feel that when health professionals go out together as volunteers serving, the communities that need them most, I always feel they get a deeper respect for each other. They learn more about what the capabilities are for each other, and they're put in an environment where they can actually see each other demonstrating what they need to do in order to have a collaborative impact on patient-centered care. So I believe as a health professional, public health professional, of course, I believe in community outreach and community service and community-based learning. And in addition to that, I feel strongly that there has to be much more emphasis placed on the training of underrepresented minorities in all the health professionals, because the research is clear that there is a much higher level of patient compliance when they are working with dentists or physicians that look like them, that understand their culture and that are sensitive to their culture. One of the largest findings with regards to the difference in outcomes for African Americans with maternal and infant mortality was the perceived quality of care that they were being provided by their healthcare professionals, and mainly because they felt that they were not being heard. They were not being listened to. And this whole aspect of how compassion needs to be integrated into care is another thing that I don't think should be dismissed, and something that I feel strongly that needs to be practiced. And if it can be taught, difficult thing to teach compassion, but a necessary thing if healthcare professionals are looking to get the outcomes that they really, really need. So resources have to be allocated for all of these things, whether it's increasing and improving interprofessional education, whether it is improving and expanding community service in community centers. We've seen now for vulnerable populations that are restricted by transportation or the other social determinants in health. We have seen through COVID that and I call them pop-up community care centers work. We have seen the influence of the churches, community centers, and that kind of thing, where the vulnerable populations live, and it is a place-based kind of a support system that also is working. So whether it's with community care centers or whether it's with mobile clinics for dentistry, whether it's school-based programs, we do have to find a way to make sure that we are very careful about how we are reading the data and the statistics when it comes to whether or not there are even real disparities, number one, and whether or not there really are shortage areas, or whether there really are there is a lack of availability of providers in areas where they're needed most. We really do have to be careful about the data. And we really do have to find ways that we can really speak to our populations and to our health professionals to do better. But we can't rely on other people to solve this problem for us, which is why going back to what you said about implementing new policy or reforming existing policy is so critical. And let's face it, there's so many times when health professionals that are minority health professionals are working so hard, their days are so filled. Sometimes they just can't take off a whole day to make a legislative visit or to testify before their state legislature or to be working with reading policy or legislation that's been put out there. It is very tedious, but it has to be done in order to be able to make a difference.
So you've talked a lot about so many things in this short period of time, and I'm so thankful and grateful. One thing that I want us to do now is give our patient audience some tips on why dental health is important and what you can do if you're a patient and you're faced with disparities in oral health care. You're not getting the highest quality care that you deserve and you know that you need. What advice would you give to patients?
Well, first and foremost, just keep thinking that dental care is medically necessary. You can't separate the mouth from the rest of the body. That tooth decay and gum disease are preventable. If you just think about those things, what you want for yourself, what you need to do as an adult in order to pass this to your children. Just because you have a lot of teeth that are extracted or you didn't have a chance to go to a good dentist or have good dental care, that doesn't mean that your children have to be the same way. Because even though there are genetic predispositions to periodontal disease and gum disease, it doesn't mean that your offspring have to have advanced periodontal disease. So it's preventable. I also would like for people to know that if they're not in a position to be able to afford dental care, there are a lot of other avenues out there. There is public insurance now for all children. And now many states have also public insurance or Medicaid for adults. And very soon, we are going to hopefully have legislation passed that includes dental care in Medicare for older patients. So for those in an audience or target population that is in a location where there is a dental school, there's also dental care that's offered at dental schools. Yes. And there are many sources for free dental care and free dental clinics that come to different areas. That's not the best, but if there is an opportunity to take advantage of the free dental clinics that are in various areas, then I would definitely say that. The National Dental Association is an organization of primarily African-American dentists, researchers, and faculty members, and they also have student groups. And so they have chapters around the country, at least 30 or 35 chapters now, I think. So that would also be another great resource for people that are really trying to seek out opportunities for dental care. The other thing I would say is prenatal dental care is not optional. It needs to be a part of basic prenatal care. So we just need to make sure that our patients know that children and adults, sadly, can die from untreated dental disease. That's the worst possible thing that can happen, but it happens. Yes. And finally, hospital dental departments are not a substitute for a dental home. We know that a lot of patients use the hospital ER because they don't have a choice, or they feel that they don't have a choice. But some of the patients that are using the hospital ERs, honestly, they're not aware of some of the other facilities or programs that may be in their city that they could really use. And again, a lot of the impetus is on health professionals, all of us, to be able to provide resources. If we are going to be a part of the solution and not continue to be part of the problem, then part of what we need to focus on is asking ourselves, what are we doing to improve health literacy? What are we doing to help our patients know that there may be some other resources there, or to give them the resources that they would need in order to help move through a system that's often very difficult to navigate. So yes, I always look in the mirror when it comes to what we can do or what kind of advice we can give our patients. I always look in the mirror and say, am I doing all that I can? Am I helping my colleagues to do all that they can? Because our patients can only do so much. They have circumstances sometimes that we cannot even imagine. And we just have to be cognizant and continue to be committed, continue to be passionate, and continue to let our voices be heard so that we can speak up for them when they can't.
Right. Thank you so much, Dr. Harper. Again, a wonderful segue to the next slide, which is to summarize our takeaway goals that each of us as professionals can do to play a part in implementing programs to help end oral health disparities in the United States. Like you said, there's things that patients need to know about the resources and what they can do, but ultimately, it's a shared responsibility with providers, dentists and non-dentists.
Yeah.
So there are a few summary goals that I want to just review. First, identify, replicate, and expand best practices to address structural and interpersonal racism and improve access and availability of affordable dental care. Number two, increase the number of continuing education courses for non-dental health professionals like myself, including oral health and cultural competency training. Number three, expand and diversify dental care the dental care workforce. Number four, improve oral systemic collaboration between dental and non-dental health professionals. And last, number five, increase the number of place-based total healthcare encounters with a dental component, such as screenings and referrals, dental services with new workforce models, information and resources for accessing community dental care. So having sort of a comprehensive dental wraparound and keeping that in mind about how to incorporate that within the overall goals of medical care. So thank you again, Dr. Harper, for being a part of this series. It is always a pleasure to spend time with you. And for those of us who are watching, please join me here at CME Outfitters for our upcoming podcasts and activities with more action steps against health disparities, including an upcoming briefcase, which is a patient case study in oral health. You can find out about all the upcoming live events and previous ones on the DNI Hub at the link here. In particular, two of our upcoming podcasts will examine diversity and inclusivity in two important areas, dermatology and chronic pain. We'll be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an impact on these important issues. Only together are we going to solve these problems. Please remember to collect credit for today's activity by using the Apply for Credit button that you see on your screen. And again, thank you once again, Dr. Harper, for your input today, for your inspiration, and for all of the work that you do to provide equitable and holistic care to patients around the globe.